Hello, everyone. Welcome to our webinar today. Thank you for joining us. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health, and I work with the Program for Injury Prevention, Education, and Research, also known as PIPER. And we facilitate the National Peer Learning Team on Child Maltreatment Prevention, which is a national network of people from various sectors who are working together to learn about primary prevention approaches to child maltreatment. The NPLT is funded by the Centers for Disease Control and Prevention and is a joint effort of PIPER at the Colorado School of Public Health and the Colorado Department of Public Health and Environment. And we're very excited to be here today to host the fourth in our series of Research in Progress webinars on preventing adverse childhood experiences and child maltreatment. So the focus of today's webinar is gun violence as an adverse childhood experience, reflections from research and practice perspectives. And thanks again for joining us today. A few housekeeping items before we get started. All participants today are muted by Zoom, but you can use the Q&A feature to ask questions throughout the session, and we'll have time at the end of the presentations to take your questions. So definitely encourage you to enter your questions as we go in the Q&A box. Also, this session is being recorded, and the link will be sent out by email with the slides and posted to our website after the session. I want to draw your attention to some prior webinars that were part of this series. You can access all of these on our website. You can view the slides and the recordings, and I'll put the link in the chat box in a moment for this to make it easy for you to access. But they've covered a range of topics on policies to prevent child sexual abuse, strategies for cross-sector approaches to building community resilience, and also the intersection of opioids and child maltreatment. So encourage you to check those out if you're interested in those topics. And also please register for some of the upcoming webinars in our series. The titles are here, covering a range of different topics coming up, including pre-birth household challenges and looking at early childhood ACE scores from Jared Parrish, based in Alaska in October. In November, we'll hear from a team out of the University of Washington looking at the Earned Income Tax Credit and strategies to promote economic stability to reduce child maltreatment. And in December, community level interventions to address ACEs from a team based here in Colorado. So definitely register for those. And as always with our series, before we get started, I'm going to do a quick poll so that our presenters have a sense of who's joining us today and can tailor their presentations a bit to you all. So please take a moment and let us know what sector you primarily work in: public health, medical care, social services, K-12 education, research or higher education, business or nonprofits, or other. And if you choose other, please feel free to share in the chat box where you're from. And I see most folks have voted at this point. I'll give it just a few more seconds and then I'll share these results. Okay, great. So let's see. So 35% of our audience today is from public health, followed by, looks like social services is next at 20%, and medical care, nonprofits, and research. So great. I'm going to close the polling now. And I see folks are putting in the chat box other places they're from: CASA, law enforcement, injury prevention for a trauma center. Great. Wonderful. Well, thank you all for being here. I'm going to quickly introduce our presenters and then I'll turn it over to them to get started. So we have a fantastic team sharing today. We have Sonali Rajan, who's an associate professor at Columbia University. She's a school violence prevention expert who studies gun violence and adverse childhood experiences. And for the past decade, she's worked on the implementation and evaluation of health education and behavioral health initiatives aimed to mitigate youth engagement in high-risk behaviors and promote positive youth development, primarily in New York City public schools, but also in other hospital and community-based settings. We also have Dr. Danielle Kassow. She's a research scientist and leader in the early childhood, early learning field with extensive experience on both the East and West Coasts. She began her career as a special education public high school teacher in a rural, impoverished, and high-risk community in upstate New York, and went on to obtain a doctoral degree in educational psychology and methodology, and has dedicated her career to the well-being of children, families, and communities. And last but not least, I'm pleased to introduce Dr. Virginia Rao. She's been a member of Columbia's faculty since 1984 and is Deputy Director of the Columbia Center for Children's Environmental Health. Her work focuses on the adverse impact of exposure to air pollutants, including secondhand smoke and pesticides on pregnancy and child health, and the susceptibility of individuals in disadvantaged populations to environmental hazards. So thank you all so much for being here today and taking the time to share your important work. And audience members, please remember to put your questions in the Q&A box, and we'll field those questions after the presentations. So I'm going to stop sharing now and invite Dr. Rajan to share her slides.
Okay, I had to unmute myself. The great Zoom mistake that we all make. So thank you so much, Sarah, for having us here today. It's really such a pleasure. It's been really nice to see the breadth of work that's being shared, research and practice-wise, through this series. So really just very excited to be here today and to see that there are so many of you joining from all across the country. That's actually very cool. So I am thrilled to be here to be presenting alongside my wonderful colleagues, Dr. Kassow and Dr. Rao, and we're going to be talking today about adverse childhood experiences. We're going to be talking a little bit about how COVID has amplified some of these experiences for children across the US. We're going to look specifically at gun violence as an example of an adverse childhood experience, and then we'll go into some reflections from the practice perspective, and you'll hear from Drs. Kassow and Dr. Rao about the wonderful work that Trauma Free NYC is doing on the ground in this context. So we're really excited to be here. And again, we look forward to hearing questions and hopefully having time at the end for a little bit of a discussion. So I'm just going to dive right in, and I know so many of you already know this, but just to sort of orient us and bring us to the same page here and make sure we all understand what we're talking about when we talk about an adverse childhood experience. So I'll use the acronym ACEs for short, just so I'm not saying that over and over again. But ACEs are really defined as stressful or deeply traumatic events that do impact the healthy development of children through adolescence and way into adulthood. And they're very prevalent. So we're going to go into a little bit more about the specifics of prevalence of certain ACEs in a few slides. But right now, about 2/3 of adults or so report experiencing or having experienced at least one ACE during childhood. And many people report experiencing multiple ACEs. Typically, research on ACEs, the origins of this field really are housed in the area of child maltreatment, household dysfunction, and we're going to talk quite a bit about this actually today, but they're now understood to incorporate a wider range of events, youth experiences with the juvenile justice system, parental absence, that kind of thing. So this is ACEs a little bit in a nutshell, and I love this image you can see here, which Drs. Kassow and Rao shared with me actually last week when we were talking about putting these slides together, because it really underscores what we're going to be talking about today, which is that you have ACEs that occur within a household. So you can see on that green tree there, you know, everything from parental mental illness, emotional abuse, maternal depression. But then we also have things that are occurring, and we're seeing this happen right now, right, in many of our communities, things that are happening in the context of the climate crisis, wildfires, things like that, other forms of natural disasters, which can certainly be ACEs in and of themselves. We also see how community-wide experiences or systemic issues, poverty, structural racism, how those really contribute to many of the traditional ACEs we see in the first place, and are ACEs in and of themselves. And so one of the things that we have been in continued conversation about is how are we defining ACEs? What is the role of us as researchers and practitioners to make sure that the way in which we're talking about ACEs really is reflective of what children are going through, what they're enduring currently. And so that's something that's been a source of conversation. I love this image. This is from the Centers for Disease Control and Prevention. And what I like about it is that it sort of underscores why intervening on ACEs, providing support for children, is so critically important. So what you see at the bottom here of this pyramid is adverse childhood experiences. And without any sort of intervention, support, resources to support kids who have gone through different kinds of ACEs, we can then see how ACEs lead to disrupted neurodevelopment, which then can lead to social, emotional, and cognitive impairment, which in turn can lead to the adoption of high-risk behavior. So that's actually a lot of where my work and my colleagues' work sit in the context of intervening on different high-risk behaviors among teenagers, for example. That can then lead to increased likelihood for disease, disability, other social problems. And that can, without intervention, without support, without resources, can lead to early death. And so the reason we care so deeply about understanding ACEs, intervening on them, supporting children who have had ACEs of various kinds, is because by doing so, we can actually prevent this pyramid from escalating in the way you see here. And in some of the work that my colleagues and I have done, in just in the process of reviewing the endless literature that does exist, it's really unbelievable how ACEs are tied to any number of poor health and learning outcomes among children and well into adulthood. Poor mental illness, substance use, poor learning outcomes, chronic health issues, increased likelihood for cancer. I mean, you name it. If you can name a health outcome or a learning outcome, it probably is tied in some way back to having had an ACE in some way. And so the implications for understanding and intervening and then responding to ACEs during childhood and adolescence is so critically important. So right now, and I know many of you probably do this in your own work, so I'm really just I'm going to summarize this very briefly, but right now we screen for ACEs predominantly in clinical settings. So what happens is you often have a child who is interacting with the healthcare system for some reason, and in that process, their pediatrician or a social worker or just someone else in that system will screen for has this child experienced any number of ACEs. And what we want to do is make the screening of ACEs a little bit more accessible and maybe think about ways we can do that go outside of the healthcare system, so we're really capturing children who are experiencing ACEs of different kinds. But the good part about screening for ACEs is that by doing so, we can then refer kids to a grief counseling program or to a social worker or to an appropriate resource, which is so, again, important. If we go back to that pyramid we were talking about earlier, that intervention piece is so critically important. Now, the challenge here, and I think we're going to hear a little bit more about this later today, is that the ability to make these kinds of referrals is truthfully contingent upon a family and a community's ability to access existing interventions. So the good news is there are an innumerable number of evidence-based interventions that do address a wide-ranging number of the health issues that are linked to ACEs, but many of these are not readily available to the communities who need them most. So if I were thinking about where is there a gap in the research to practice sort of component here, to me, this is a huge opportunity that us as practitioners, educators, physicians have an opportunity to really think about how can we fill this. I talked a little bit about this earlier, and this sort of just brings it home a bit. What ACEs, so right, the sort of list here you see are the typical ACEs that are often screened for: child maltreatment, etc., death of a primary caregiver. And these are all very much ACEs, and what we are trying to do in our collective work is think about how we expand upon our definition of ACEs to more accurately capture the experiences of children right now. So as I was mentioning earlier, ACEs persist across the US and in different communities. About 45% of children have reported, so the statistic I gave before was data that came from adults, but if we look at children currently, the most recent data suggests that about 45% of children or so have experienced at least one ACE. And ACEs disproportionately impact Black children in particular. So just about over 6 in 10 Black children report having had ACEs compared to their white peers. As children get older, we start to see ACEs also accumulate. So if we start incorporating other experiences experiences, let's say with the juvenile justice system, with gun violence, with other forms of ACEs, there's a cumulative effect as well that we need to consider in our work. There is some research that suggests that ACEs also disproportionately impact urban areas. There's been some work, the Philadelphia Urban ACE Survey. I really they've been collecting data on community trauma and other adverse childhood experiences among Philadelphia residents. And so in their sample among adults in Philadelphia, we see that over a third of individuals report experiencing emotional abuse during childhood. Over 40% report witnessing violence while growing up. Again, another third report experiencing discrimination based on their race or ethnicity. So we do start to see how ACEs are just so prevalent. I mean, these are pretty staggering numbers. And when you think about how many people are experiencing ACEs of different kinds, it's really important to understand that there's opportunity for intervention, there's opportunity for support. So one of the questions that we are all contending with right now, and I'm sure many of you are thinking about this in your own work, is COVID-19 an adverse childhood experience? And how is that tying into the way in which we support children and we think about their families, we think about their well-being, we think about the role of schools as children start to go back to school? So during this pandemic, ACEs have tragically been amplified. We have seen increased job loss and economic instability among homes, increased housing instability, of course, increased illness and death among families. The nature of school closures, lack of childcare has, of course, resulted in its own set of instabilities for family and for children, with links and implications for poor mental health and well-being. We have seen over the past few months heightened police brutality in various ways, and we have also seen an observed uptick in other forms of gun violence. And so I'm going to talk in a few minutes just specifically about the gun violence component, but COVID has really amplified so many inequities, so much trauma, and this is, I think all of us moving forward have to consider all of this and the ways in which we do our research and the ways we then translate our efforts into practice. So I'm going to shift just for a moment now to talk specifically about gun violence and how we are in our work trying to advocate for gun violence exposure during childhood to be considered an adverse childhood experience. So just to orient ourselves to this as a public health issue, gun violence persists in the United States. On average, about 100,000 Americans are injured with a firearm every year, with over 17,000 of these individuals being children. And about 38,000 individuals die as a result of their firearm injuries. And this is a persistent public health issue. It is actually not considered an epidemic, it's an endemic because it's no longer an emerging threat. It is a persistent, ongoing public health crisis. The work that my colleagues and I have done has really tried to pose a question to ourselves and to the practice work that we engage in, which is to say that exposure to gun violence also goes beyond injury or death from a firearm. So the statistics you see in this top bullet here really don't reflect the broader spectrum of gun violence experiences and exposure that many children do go through, but that we have historically not accounted for in our work and our practice. So just some examples, children who witness gunfire, who might hear gunshots as they're walking to and from school, who have maybe lost a friend or a family member to firearm-related injuries or death. These are all examples of types of gun violence exposure that are typically not captured in our existing data sets as gun violence, but very much are. I'm including just a couple of these are just headlines from the past couple months that we have been all seen in the news, the intersection of gun violence and COVID, the intersection of gun violence and police violence, and the fact that gun violence during this time has continued to rise at fairly alarming rates in large US cities, but also in other forms, for example, via firearm suicide. And so I share this here just to say that this is a persistent issue that has in many ways gotten worse over the past few months. And we again need to consider this in our work. this is a graph related to this from the New York Times that talks about that partially explains why we might be seeing this uptick in violence. And I'm going to also just preface all this by saying there's so much we really don't know about what's been happening right now. And I imagine that there will be studies coming out in the next several months and years that really examine this period as its own entity. But right now we are seeing, for example, that over 2 million guns were sold in the US as COVID spread. And so you can kind of see this graph here where we see some ebbs and flows in firearm purchasing. So the uptick in firearms is potentially linked to this uptick in violence. I am going backwards here. So in the work that my colleagues and I have done, and we published a paper last year in the Journal of Behavioral Medicine, there was a special issue devoted to the issue of firearm violence, which I was so happy to see such wonderful work coming together and examining this issue from various perspectives. The work that we contributed in that way was really to try and look at the existing research on gun violence, the existing research on ACEs, and see if we could reasonably make a case that exposure to gun violence as a child should be considered an ACE. And some of you might be asking, how is this not already being captured in ACE screening measures? And there are multiple reasons for this. Part of it is we are capturing it sort of indirectly. So when you can say a child might have lost a friend or a family member to gun violence, we might capture that they've had a death in their family, for example, but we're not capturing necessarily the mechanism through which that happened. There's also political reasons why gun violence, being a historically understudied and underfunded issue, has not necessarily been thought of as an ACE. It's been thought of very differently. So part of our effort was to also just understand, could we, just looking at the evidence, draw some reasonable conclusions? As we talked about earlier, ACEs are stressful or traumatic events. And what we did is we reviewed, and I'm estimating now, but it's about 82 or so different journal articles that met our criteria. We reviewed literature over the course of 2 decades. And we were able to essentially illustrate the following. So we were able to show through our work that the nature of gun violence exposure and other ACEs that there are a lot of similarities, and actually to some degree some overlap in terms of how we screen and things like that. We were able to show how traditional ACEs impact a wide range of critical health outcomes, but there is some existing research that shows how gun violence exposure during childhood also does that in similar ways. We were able to identify that there's a very clear need for interventions, for resources to support individuals who have had ACEs, and also draw on the existing research to make that very same case for how kids who have been exposed to gun violence in various forms must need and warrant that support as well. And through this process, we identified some very clear gaps in practice and also in the research questions that need to be asked. And so in our work, we identified the following experiences that we are advocating in our work to say youth gun violence exposure goes far beyond firearm injury or death, and actually should include all of these experiences: witnessing gunfire, children who are regularly hearing gunshots, knowing a friend or a family member who has been shot, having a close friend or a sibling who carries a gun. And then we also talked about in our work that there is room to consider screening for these kinds of experiences regardless of location, since we know youth gun violence exposure can and does occur in homes and in schools and more generally within one's neighborhood. So really considering the community component of this as well. So some of the 3 takeaways from this particular body of work were, and I'm just keeping a quick eye on the time, is that one was the importance of including gun violence exposure, as we just defined it, as an ACE in future screening tools. So we actually looked at all the different screening tools that exist for ACEs, and we kind of document why this is so important and that how there is a gap from a screening perspective in this way. We, of course, advocate for the importance of broadening the definition of gun violence exposure to include all of these other experiences. And then, of course, the importance of expanding the notion of who should conduct screenings, potentially to increase the reach of current screening efforts, and potentially then by doing so, be able to provide referrals and support and interventions thereof. I didn't say this earlier, but I'm just thinking about it as I say it now, which is also the act of screening also allows us in our different sites of practice to know what's happening, right? So if we know that there are children who are engaging or exposed to this kind of violence, then we can also think about how we take schools, for example, which is where I do most of my work, and rework and transform schools to be trauma-informed spaces, for example, and why that's important. Or it might allow us to rethink how we as educators train our teachers or train school leadership to respond to different kinds of child behavior in and out of the classroom. So I really think about this as an opportunity to also use this as a way to examine our own day-to-day practices. So I'm going to pause, and I know I talk really fast, so I'm going to pass this along to Dr. Cassow, and she's going to take us on a series of reflections that I think will be really interesting. So Danielle, I'm going to mute myself, and I will move the slides.
Okay, thank you, Sonali. I'll tell you when to move along on the slides. Hello, everybody. I'm very happy to be here with you, and I'm very appreciative of your time and your attention today. I want to switch gears a little bit. To Sonali talked about such an intense topic during such an intense period in our country right now, and we're all dealing with a lot in our personal lives, in our professional lives, and it can feel quite heavy at times. And in addition to the pandemic, now we have these wildfires going on out west, and actually the smoke from some of the wildfires is actually over New York City right now. So I want to spend some time talking about how stress impacts the brain and the body, and also practice a tool with you that is free, that you can do for yourself to bring your body back into a calmer, balanced state, and also a tool that you could use with with clients, with your own family, with your children, or if you're a therapist, with your clients in that context. So we're going to stay with this slide for just one moment, the reflection slide. And I just want to start by asking you a couple of reflective questions that you're not going to share with me. You don't have to share with me. I just really want you to think about it for 30 seconds. You can write it down if you want. But think about, what does stress do to my brain and my body? How do I experience stress? How do I express it in my body? How do I express it physically, mentally, emotionally? So just take a moment to reflect on that. You can write your response down if you want. You can type it into your phone if you want. Okay, so Sonali, we can go to the next slide. We're going to come back to that question. So stress is part of our lives. It's part of who we are as humans. It's hardwired into us. It's not necessarily a bad thing. And we all have stress, and we have to learn how to manage stress. We have to develop tools to cope, to find solutions, to navigate difficult situations, to have difficult conversations. It's actually critical to our development, and it's critical to our survival as a species. Managing stress is critical to our survival as a species. And as I already said, not all stress is bad. Some stress is actually positive. For example, if you have a job interview coming up and you feel nervous at the job interview, maybe you're perspiring a little bit, maybe your heartbeat has raised a little bit, but that physiological response inside of you, maybe that's helping you to be more alert. Maybe that's helping you to feel a little more eager and excited for the job interview and be able to answer the questions during the interview. So this kind of stress is short-lived. and it's unlikely to have a negative effect on your health. But let's look at this, what's on the slide and what the slide is talking about. So in the slide, there are different stages of childhood where you see developmental functions or skills that are wired into our makeup. They're part of our biology. They're skills that we expect to see children develop. And why do we call them, why does the title on this side say stress is hardwired into our biology? Well, think of these as new challenges for children, and new challenges can be stressful, but again, that doesn't necessarily equate to something bad. It just means you may have to work a little bit harder at something, or maybe you have to practice the skills you're becoming good at it, so to speak. And each of these stages sets the foundation for the next stage of development. And there's an interaction and interdependence between the skills that you see on this slide. So for example, in early childhood, one of the key skills is that I have to learn how to regulate my emotions. I have to learn how to not scream when I'm having a temper tantrum because I don't understand something, and being able to ask for help, parents coaching me through or teacher coaching me through a difficult situation as a small child is going to help me when I'm in school and I'm sitting in the classroom and I need to pay attention and listen and raise my hand and learn how to do math, for example. But again, when we think about these kinds of stress, which are not necessarily, they're not bad, they're expected parts of development, there are things that can happen to children that disrupt their development. And these are things that Sonali spoke about earlier: ACEs, gun violence. COVID is not necessarily an ACE. It could become an ACE in future years. We may decide that it's an ACE, but it's definitely amplifying what we're seeing in children and in adults right now. So when there are disruptions to development, to a child's development, and by disruptions I mean toxic stress, ACEs, trauma, when these disruptions are chronic, when they are repeated exposure, when they're long-term, and there's an absence of a supportive relationship and or a lack of resources, that stress that the child is experiencing can become negative, it can become toxic, and it actually impacts the hardwiring of our brain and our biology, and it impacts our health outcomes. So I want to differentiate. There's positive stress, and then there's more toxic forms of stress. And it's those toxic forms of stress that have the repeated exposure on a person that can impact the health. And it actually changes the hardwiring in the brain and the body. If this is something that you're interested in, if you're interested in learning more about the different kinds of stress, I really would love to refer everybody to the Center on the Developing Child at Harvard University. They have a wonderful website with resources that were created for the general public. They're user-friendly, there's videos, there's graphics, there's reading materials. It's a great resource for learning more about the different kinds of stress and the impacts on the body. So we can go to the next slide. So this is what's happening to us when we're stressed. And you may recognize some of this. If you think about, go back to the question I asked you at the beginning about how does stress impact my brain and my body? How do I express it? Take a look and see if anything resonates there with you. Do you recognize any of this in yourself? Can you recall a situation where you experienced this? This is our body in what's you probably have heard as fight, flight, or freeze mode. I have to survive. So our body goes into a sympathetic nervous system. This is our sympathetic nervous system at work. And the body automatically triggers a stress response to either a stressful situation or a dangerous situation. And as I've already mentioned, these physiological experiences can be short-lived and they may not have an impact on our health. But when a person is experiencing toxic stress, ACEs, exposure to gun violence, if they've experienced a loss due to COVID, particularly if they're a child who has lost a parent, over time, the toxic stress has an impact on our body. Because when our body is in a sympathetic nervous state, as you see on the slide, when we're having these physiological symptoms and it's happening, they're getting triggered over and over again, our body is always in fight, flight, or freeze. And so the stress hormone is constantly being released and coursing through the brain and the body. And that's where we have health impacts. So as Dr. Rajan mentioned at the beginning of her presentation, any kind of health outcome that you can think about, that you may be experiencing, that you know someone who's experiencing, there's a high probability that you could link it back to experiences in childhood and throughout life, whether it's obesity, diabetes, cancer, broken bones, whatever it is. Many of those things are related to experiences and exposures that we've had throughout life. And because of what we are going through in the country right now on so many different levels, if you think about that beautiful graphic that Sonali showed at the beginning with the ACEs, the tree of our household, our community, our environment, all these things are interacting and colliding together in our country right now. It's going to have an impact on all of us. And so I feel it's very important for all of us to take time out for self-care strategies, even if it's only 5 minutes throughout different points in the day. To really help us manage the physiological manifestations of stress and the psychological and emotional toll that things can really take on us. So Sonali, could you go to the next slide? So this is our body relaxed. And this is what's called our parasympathetic nervous system, and it's working to bring our body back into balance. It's working to bring our body into a calm state, so that we don't suffer those toxic outcomes. And so what I'd like to do, if the audience is willing to humor me, and I wish I could see all of you and we were in a room together in a non-COVID world, I would like to teach you a relaxation technique that you can do for yourself anywhere, anytime. I do this sometimes when I'm on the subway in New York. I live in New York City. Nobody knows what I'm doing, so it's something you can do wherever you are. It's something you could do with your children, your clients, your patients if you're a doctor. So I'm going to lead you through a relaxation lesson, and I'm just going to pull up a timer on my phone because we don't have a ton of time today, but I'm going to invite you to get comfortable in your chair. If you're wearing eyeglasses and you'd like to take your eyeglasses off, you're welcome to do that. If you're not comfortable, if you'd rather lay down on your floor for a couple of minutes, please do that. I'm going to try to bring you back into an aware state because we still have more after I'm done with the lesson. But I'm going to invite you to close your eyes. I'm going to close my eyes, and you're welcome to do that as well. And I'm going to lead us through the lesson, and I am going to have one eye on a timer. So just breathe and focus on your breath, bringing your awareness to your breath, seeing if you can notice what happens as you gently inhale and gently exhale. You don't need to change anything about the way that you're breathing. You don't need to do anything different. Just keep noticing your breath. And see if you can notice if you're holding any tension around your eyes and your upper cheeks. As you're gently inhaling and exhaling, can you feel any tension above your eyes? Maybe you can let go of. Just keep breathing in gently and exhaling gently. Noticing where you can let go of any tension you might be feeling in the eyes, or perhaps in your jaw. Are you clenching your jaw? Can you make some space in between your upper teeth and lower teeth? Maybe by opening and closing your mouth gently a few times, but leaving space there. See if you notice which way your nose is pointing. Is it pointing a bit to the left, maybe to the right? Perhaps it's in the center. Gently inhaling and exhaling. You don't need to change the direction that your nose is pointing. Just see what you notice. As you continue to let go of any tension you might be feeling in your face, around your eyes, in your jaw. And see if you can sense or even see in your mind's eye, how close is my right ear to my right shoulder and my left ear to my left shoulder? Is there tension in my shoulders that's hiking them up towards my ears? Can I perhaps let go of my shoulders, releasing any tension I might be holding in them, or tension I might be feeling in my neck, in the front of my neck or the back of my neck? And if this feels comfortable for you, you can place one hand on your chest, your upper chest, above the breast, and one hand on your lower belly, and just breathe. What do you notice moving as you're gently breathing in and breathing out? As you inhale, can you feel your lower belly expand and your chest rise up? And as you exhale gently, not forcing it out, can you sense your belly button going back towards your spine and your chest moving down towards the diaphragm? Just see what you notice as you gently inhale. That was the timer. Stay with me. I'm sorry that wasn't on silent. I thought that it was. Just continue to see what you notice as you gently inhale and exhale. Enjoying this moment to relax, pushing aside any thoughts that may come in, just continuing to focus on the breath and letting go of any tension that you might feel in your face, your jaw, your neck and shoulders. Breathing at your own natural pace without judgment. And without needing to change the way that you're breathing. So in the interest of time, when you're ready, you can gently open your eyes and let the world come to you. And maybe roll your shoulders a little bit, move around in your seat, move your arms, and just stay in that relaxed state if you can. As I pass the baton to Dr. Rao, and again, I want to thank everybody for going on that little journey with me. And as I said, that's a free tool that you can use for yourself. It doesn't have to have a particular script to it. It doesn't have to have a script at all. If you can remember 2 things, which is just, putting the hand on the chest and the stomach, if that's comfortable for you, and trying to see if you notice any tension in the face, the jaw, the neck, and the shoulders, and letting go of that as you breathe in and breathe out, then that's a wonderful thing to be able to take away today. Okay, thank you.
Okay, well, thank you to both Dr. Rajan and Dr. Kassow for bringing us to this point. We have a few more slides and then would like to open things up for discussion. I want to introduce a collaborative called Trauma Free NYC, which is dedicated to promoting awareness, research, and training about the effects of trauma and sources of resilience, both individually and in the community. I would like to say that Trauma Free NYC is just one of many organizations around the country that is dedicated to addressing some of the issues which both Sonali and Danielle address. Next slide, please. Just a little bit about who we are. Founded about 3 years ago as a Columbia University-based initiative focused on identifying trauma-informed practices and policies, specifically in New York City. We represent an interdisciplinary group across the university. Our group is directed by the Mailman School of Public Health. We have representation from a variety of schools within the Columbia system, Teachers College, departments of psychology, epidemiology at Mailman School of Public Health, developmental psychobiology, and even the Dart Center for Journalism and Trauma. We began by hosting a book talk with Dr. Nadine Burke-Harris in 2018. She was launching her book, the beginning of her book tour in New York City at that time. She is the author of The Deepest Well. Highly recommend this. Dr. Burke-Harris was a pediatrician from California and really has done a great deal to raise awareness and introduce the term ACEs to more common usage. In 2019, at the School of Public Health, we launched our first interdisciplinary service learning course that includes a field service component with local service agencies in New York City. We continue to offer this trauma-related course, and now more than ever, this has been an important component of our curriculum. Also in 2019, Trauma Free NYC Student Advocate Group launched. I will say they launched themselves. Students recognizing the importance of this topic, particularly in these times. Next slide, please. So what we do specifically is to serve as a science advisor and resource to policymakers, practitioners, and actually the entire public health community. We promote research and demonstration activities in an effort to find solutions to reduce some of the harmful effects of childhood adversity and some of the issues that you've heard this afternoon. We design educational training and service learning programs in trauma-informed practices at Columbia University. Next, please. So these are some of the recommended reading. I previously mentioned from Dr. Burke-Harris, The Deepest Well, Healing the Long-Term Effects of Childhood Adversity. In keeping with what Danielle has offered today, The Body Keeps Score, Brain, Mind, and the Body in the Healing of Trauma, very important perspective. And finally, another selection, Trauma Stewardship, an everyday guide to caring for self while caring for others. Next slide, please. So there are a number of things I hope that we have left you with. First, Sonali gave a very good overview of our definition of ACEs. We want to think about ACEs being a more inclusive term and to be more comprehensive, to take into consideration a whole range of potentially negative experiences. I think it was underscored in Sonali's slides that ACEs are not just isolated moments. We could consider adverse childhood experiences as often very chronic. Screening and subsequent efforts to intervene and support children and families must better reflect the fact that this is chronic, ongoing conditions that affect children at various life stages. And finally, there are important systemic issues, extremely clear, I think, in this very stressful time of the pandemic. These are also sources of trauma and must be accounted for when we try to screen for ACEs. These issues drive whether or not a child has access to comprehensive support, care, interventions, and other resources. And I think has been demonstrated, certainly in the US and potentially globally, the pandemic has raised public awareness of some of the inequities. This has critical implications for the ways in which ACEs impact children in the long run. Next slide, please. So what we would like to do in the few remaining moments is to take a few questions. I think we will turn the slides back to our moderator and see what's in the chat box and the Q&A and see if we can try to address some of your very specific questions.
Yes, thank you all so much for a great talk. Really appreciate it. And I think it's so important that we think about this and think about gun violence in the context of COVID and sort of the collective and individual traumas that people are experiencing right now. So appreciate you sharing this information with us. I'd like to take moderator privilege, if I may, and ask the first question, which I always think about as we talk about ACEs, which is really around prevention and where we focus given kind of the scope of the challenges that we know children are facing right now and that adults are experiencing because in part of the adversity that they faced as children. And so I wonder if you all could speak to kind of the tension between focusing on mitigating the effects of trauma versus preventing trauma from happening, and particularly as we think about gun violence, sort of how you think about that balance.
Sure. So I think in an ideal world, we would prevent ACEs from occurring in the first place, and we would have the resources in place to ensure that we could comprehensively, unequivocally support children who had experienced ACEs, and there would be room for both. And there should be room for both in that context. I think the hat that I wear often is that there are many ACEs that might just be difficult to prevent like an unintentional injury, for example, or death of a family member. Like some types of injury there's room for prevention on every type of ACE we talked about, but some might be easier to prevent in their entirety versus others. So I think a lot about the ways in which we are missing gaps in intervention and support. For example, so a lot like maybe there's a role in which pediatricians in the clinical setting has played a wonderful role in trying to screen and provide referrals, but there are opportunities potentially for schools, for school nurses, for other folks in other sectors to help fill that gap. And I think Trauma Free NYC has done a nice job of trying to underscore those missed opportunities. But that being said, with regard to gun violence in particular, the majority of injury and death and exposure from gun violence is preventable. We just need to implement a comprehensive preventive strategy around gun violence that we see on other public health issues, but have historically not seen on gun violence, in large partly due to a lack of political will and under a lack of funding for good quality research and things like that. So I think actually a lot of the ACEs associated with gun violence have a lot of potential to be prevented in and of themselves. What gives me a lot of optimism in this space is knowing that there are so many wonderful people doing that difficult research, that we are starting to see an increase in available funding opportunities for gun violence prevention research, for the scientific study thereof. So I do see that there is I feel actually a lot of optimism around that particular issue. It's my own bias too, because that's the issue I spend a lot of my time thinking about. But so that's my non-answer for you, Sarah. I think there's room for both, and I think we need to have those conversations constantly. And really, and then again, also just expanding, like those of us who are behavioral scientists, we should be talking to the folks who are doing the climate science work, right? And understanding where the overlap there is, for example. So I'll pause, but I'm curious what.
No, that's great. Thank you. And I want to, I appreciate that. And I think it is a challenging balance always to find. I want to go on. We probably won't get to every question. So I want to ask if it would be okay if folks reach out to you all as well after the session with questions, and we'll send out that information to everyone who registered today. But I do want to turn to Terrence's question, which gets to sort of different contexts. He asks about, is every kid in Alaska experiencing ACEs from guns, and notes that Alaskans carry firearms for protection from animals and other dangers. Almost every household has firearms. How do you think about gun violence in rural versus urban contexts? Think about different forms like suicide versus interpersonal violence, and what that means as we think about ACEs for children.
So my husband grew up on a farm in upstate New York, so I'm very familiar with that culture around gun carrying, and also around the reasons by which families and communities do possess guns. And and most those of us in the research community are not anti-firearm, we're anti-firearm violence. So I always try to underscore that piece of it. I will say yes, absolutely, Terrence, you're absolutely correct. The context matters. I do think that, recognizing that there might be an unintentional injury from a hunting accident, when we're communicating about that and we're talking about the prevention of that, that's very different than children who are in school experiencing active shooter drills, which are drills in place to respond to the prevention of intentional violence. And so I do think that when we think about ACEs, the context is there, and really we're talking about it's like the anticipation of intentional violence is there. Yeah, it's different than accidental, than like a fire drill, for example, which is framed more as an accident. And I do think that matters. I think that matters quite a bit in how we develop trainings and how we support kids. So I don't know if that makes sense the way I'm saying it. And maybe Daniel and Ginny have other thoughts, but yeah.
Anything to add? I think we have time for one more question, so I'm going to squeeze one more in if I may. Oh, did you want to jump in?
The one thing I will add, I was reading Terrence's question as well, and I started out as a high school teacher in upstate New York, and I remember, and I grew up close to the city, but I do remember at the beginning of hunting season, the principal making an announcement over the loudspeaker: if you're going to go hunting before the school day starts, make sure you don't bring your gun into school, and you can't park your car on campus. And I was like, what? Because I didn't grow up in a hunting community. And so I agree with Dr. Rajan. I think context really does matter. And we're really referring to the violent exposure to guns. Sarah, there is a question, I think, from one of our students at Mailman, Taylor Fish. This is the Taylor Fish that was in our class last semester. She's asking about opinions on school shootings, active shooter drills. And Sonali, off the top of your head, do you remember the web address to the our podcast we did? I mean, people can find the podcast on our website, but where else is it?
I do. Okay, so yeah, this is so, and again, we're very open. We love to talk over email or Twitter or whatever. So please do. I'd love to continue this conversation. So we do have a podcast which we featured Danielle and some of her wonderful work in our second episode. It's a podcast produced with the Media and Social Change Lab. And my wonderful colleague Lolita, who directs that lab, just sent me the link so I can share it with everybody. Thank you, Lolita, you're the best. So I will put that in the chat box, but it's called Research for Solutions. And you can actually find it on the Trauma Free NYC website, as well as if you go to the Media and Social Change website, we link to it there. So we'll put that in the chat box so everyone can access it, but you can hear a little bit more about some of the work we're doing in this space to look at that intersection of ACEs, school safety, and gun violence. So I'll put that in there.
Wonderful. Well, thank you. I'm sorry that we're out of time, but I so appreciate you all joining us today, and I encourage you to continue the conversation over email from here. And I hope everyone has a great rest of your day. Don't forget to sign up for the future webinars in our series and continue to connect with us around these topics. Okay, thank you again to our presenters today.
Thank you, guys.
Take care and have a great day.
Thank you.